Welcome to Revitalize Education. In this video, we continue with our series on vascular emergencies, focusing on how aortic dissections are treated. If you haven't already seen our previous videos discussing the pathology, clinical presentation, and diagnosis of aortic dissections, make sure to check those out. Otherwise, let's jump right in. Determining the location and extent of the aortic dissection is important in determining the appropriate treatment plan. A type A dissection, including the ascending aorta, are surgical emergencies, whereas a type B dissection of the descending aorta are more often medically managed. If a type A dissection is diagnosed and an immediate cardiovascular surgical consult is needed. If a cardiovascular surgery center is not available at the institution, prompt transfer to a facility with the available cardiovascular surgery is needed to achieve optimal outcomes. When preparing for the operating room or while en route to an appropriate cardiovascular surgical center, there are several medical interventions that we can implement. Our goal with our medical treatment is to decrease the shearing forces and limit dissection progression through lowering the patient's heart rate and blood pressure. These patients often experience severe pain, which in turn may increase their blood pressure and heart rate. Therefore, administering opioids such as fentanyl or morphine may help manage pain and decrease their sympathetic tone. Some sources recommend PCAs or patient-controlled analgesia as a delivery method to give the patient more control over their own pain management. While pain management is important, one of the most important things that we can do to minimize the damaging effects of the dissection is decreasing the shearing forces, which is done through lowering the heart rate and the blood pressure. Every time the heart beats, the pressure of the systolic blood pressure is exerted on the intimal tear, which can result in the expansion of the dissection. Therefore, our treatment goals include decreasing the heart rate or the frequency that the intimal tear sees that high blood pressure, as well as decreasing the overall systolic blood pressure. Fast-acting IV beta blockers, such as esmolol or labetalol, are most commonly used to decrease the heart rate. If beta blockers are contraindicated, calcium channel blockers, such as verapamil, may be used but tend to be less effective. The goal is to decrease the heart rate to about 60 beats per minute. Esmolol is a selective beta-1 adrenergic receptor blocker. It is generally used as a continuous infusion with a dose of 25 to 300 mics per kilogram per minute. Esmolol can be uptitrated every 2 to 5 minutes by 25 to 50 mics, with a max of 300 micrograms per kilo per minute, until a heart rate of 60 can be obtained. Some institutions recommend using a loading dose of 500 mics per kilo, which can be rebolused with every uptitration in an effort to more rapidly achieve the goal heart rate of 60. Labetalol is another possible agent used to decrease the heart rate. It's a non-selective beta-adrenergic receptor blocker and can be administered either through IV boluses or a continuous IV infusion. While either option is acceptable, it's important to note the importance of avoiding fluctuations in blood pressure and heart rate. Therefore, IV infusion is the preferred method of administration. A labetalol infusion is generally started at 0.5 milligrams per minute and can be uptitrated by 0.5 milligrams per minute every 30 minutes until you reach a max dose of 10 milligrams a minute. It's important to note that while beta blockers are the preferred treatment option to lower the patient's heart rate, beta blockers should not be used in patients who have used cocaine or other stimulants within the last 12 hours. Beta blockers are contraindicated in patients who have used cocaine or other stimulants within the last 12 hours. The sympathomimetic action of cocaine has both peripheral and central mechanisms. Cocaine prevents reuptake of norepinephrine and therefore increases sympathetic tone. Cocaine causes several cardiovascular effects, including vasoconstriction, hypertension, tachycardia, and thrombogenesis. Vasoconstriction results from the stimulation of the alpha receptors. Therefore, the use of beta blockers in a patient with cocaine may lead to unopposed alpha stimulation, causing a worsening in hypertension. Therefore, if cocaine is present in the setting of an aortic dissection, benzodiazepines are considered the first-line treatment of cocaine-induced hypertension. Benzos, such as Ativan, Versed, or Valium, inhibit the sympathetic actions of cocaine and often lower the patient's blood pressure and heart rate. If benzodiazepines are unsuccessful at lowering the patient's blood pressure and heart rate, other agents such as phenethylamine or nitroglycerin may be added in an attempt to decrease the blood pressure. Once the heart rate is controlled or the beta blocker infusion max has been reached, the next priority is to limit the dissection progression by lowering the blood pressure. The systolic blood pressure goal is 100 to 120 millimeters of mercury. While several agents can be used to lower the blood pressure, the most commonly used agents are nipride or nicardipine. Nipride, also known as nitroprusside, causes peripheral vasodilation by direct relaxation of the vascular smooth muscle. The recommended dose is 0.5 to 10 mics per kg per minute. It is imperative to note that when nipride combines with hemoglobin, it is metabolized into cyanide. Therefore, except when used briefly or at low infusion rates, such as less than 2 mics per kg per minute, nipride can produce toxic levels of cyanide. Nipride infusions at the maximum dose rate of 10 mics per kg per minute should never last more than 10 minutes. If blood pressure still has not been adequately controlled after 10 minutes of infusion at the maximum rate, the nipride infusion should be terminated immediately. Due to the potential consequences of cyanide toxicity with nipride, nicardipine may be the preferred agent. Nicardipine is a calcium channel blocker that is moderately effective at lowering the patient's blood pressure. The recommended dose is 5 to 15 milligrams an hour. It can be uptitrated by 2.5 milligrams an hour every 5 minutes to a max of 15 milligrams per hour, or until the blood pressure parameters have been met. Some institutions opt to use other vasodilators, such as Clevoprex or phenyldipam. However, these do not seem to be as effective as nicardipine or nipride at lowering the patient's blood pressure. Up until this point, we have discussed management techniques for an aortic dissection patient presenting with hypertension. While the majority of patients present with hypertension, there is potential that the patient may experience hypotension. There are three main causes for hypotension in a dissection patient. The most severe causes are rupture of the aorta or a pericardial tamponade. If a tamponade is suspected or diagnosed and the patient is in a peri-arrest state, a pericardiocentesis should be performed. Hypotension may also be pseudohypotension, where the intimal flap obstructs the blood flow in the extremity in which the blood pressure is being monitored. This is another reason to make sure the blood pressures are measured in both arms. The arm with the higher blood pressure should be used to guide the fluid resuscitation. Hypotension in the presence of an aortic dissection requires prompt intervention. Surgical intervention or rapid transport to a facility with cardiovascular surgical interventions is of utmost importance. Fluid resuscitation may be required to maintain perfusion. Due to the risk of hypertension and worsening of the dissection, permissive hypotension is allowed with a systolic blood pressure goal of greater than 80 millimeters of mercury or a MAP of 65 millimeters of mercury. Fluid resuscitation may be accomplished with 1 liter of saline, however, blood products are the preferred resuscitation product. It's recommended to administer blood products in a 1:1:1 ratio, starting with plasma in an effort to replace the clotting factors, followed by 1 unit of packed red blood cells and then 1 unit of platelets. While we have discussed medical management of both hyper and hypotensive aortic dissections, we cannot lose sight of the fact that surgery is the ultimate treatment for all type A dissections and any type B dissection with evidence of poor perfusion. Without surgical intervention, patients with type A dissections are at high risk for life-threatening complications, such as aortic regurgitation, cardiac tamponade, stroke, frank rupture of the aorta, myocardial infarction, and organ malperfusion. Mortality rates increase 1 to 2% per hour after the onset of symptoms. Therefore, rapid surgical intervention is imperative. Generally, type A dissections are taken to the OR immediately, whereas type B dissections with evidence of malperfusion generally undergo urgent surgery within 24 to 48 hours of diagnosis. Any type B dissection without evidence of malperfusion is generally medically managed. The surgical intervention may be through an endovascular approach. However, most type A dissections are managed using an open surgical technique. The goal for surgery includes excising the intimal tear, obliterating the entry into the false lumen, reconstructing the aorta with a synthetic graft, and depending on aortic valve involvement, the aortic valve may be repaired or replaced. After surgical intervention, aortic dissection patients, especially type A dissections, remain at risk for long-term complications. Generally, patients remain on oral medications to ensure that heart rate and blood pressure are controlled to limit aortic wall shear stress. After surgical repair, patients undergo MRI or CT imaging prior to discharge and undergo subsequent lifelong imaging surveillance. Most patients have residual dissections in the distal aorta. Therefore, it's important to monitor for signs of progression. Due to improvement in operative techniques and post-op care, in-hospital mortality following type A dissection repair has decreased dramatically. The 5-year survival for patients who leave the hospital is estimated at 68%, and the 10-year survival is estimated at about 52%. Long-term survival rates are similar among type A and type B dissections. In this video series, we have discussed vascular emergencies, how to recognize and diagnose them, as well as treatment priorities. We hope that through these videos, you have a better understanding of vascular emergencies and are more confident in recognizing and treating aortic dissections. From all of us here at Revitalize Education, thanks for watching. Make sure to hit the like button and subscribe to stay up to date on all of our videos.